Hi.
Uh, Naveen
Hello,
sir,
Minu.
Sir, good evening.
Good evening.
All
नमस्कार
sir,
मैडम
good evening.
Sir, good evening, Dr.
Dr.
Naveen.
Naveen, good evening.
नमस्कार मैडम नमस्कार Dr. Parul, we are live now and you are the host
Hello,
now,
Minu.
so we can start.
जी
Sir, good evening.
Good evening, Dr. Naveen.
All
नमस्कार
sir, good evening.
सर नमस्कार
Sir, good evening, Dr.
Dr.
Naveen.
Naveen, good evening.
नमस्कार मैडम नमस्कार Dr. Parul, we are live now
जी
and
सर
you are the host now, so we can start.
जी
Sir, good evening.
Good evening, Dr. Naveen.
All sir, good evening.
Good evening everyone. Good evening respected Tej Call sir, President Dr. Naveen Malhotra sir, Honorary Secretary Dr. Vishal Singla sir, esteemed GC members of RSA and our dear audience. It is a matter of immense pride that RSA Uttarakhand is hosting this webinar today. May I request our Honorable President sir to address this august gathering.
Thank you, Dr. Parul and Dr. Tejke Kaul sir, Office Bearers of Research Society of Anaesthesiology, National and Uttarakhand State Branch, my fellow colleagues in the Governing Council. Today's webinar is according to the things which are going on in the country. AI has been the thing of 2026, and we doctors and in the Society of Anesthesiology also should not be left behind and be in sync with the things which are happening in the nation and globally. So I'm very sure that today's webinar will throw more lights, especially on the ethical considerations for anesthesiologists and also the clinical applications. In below every AI generated thing, there is a footnote that this data is not verified. So I am very sure today whatever you will be talking will be verified. So all the ethical things which we will be discussing, they will be verified. So my best wishes to the panelists and thank you for conducting this webinar. Thank you, Dr. Parul, Dr. Bhavna, Mr. Tripathi, Dr. Kamna, and other panelists. Thank you very much.
Thank you so much, sir, for your kind words of encouragement and support. You've always guided us, and thank you so much for everything. So we'll start with the panel discussion without wasting much time today.
Can we have word of blessings from Dr. Tejke Kaul, sir? Sir, few words of
Please,
blessing
sir.
from your side. Unmute, sir. Dr. Tejke Kaul, sir.
Good evening, everybody. A great day today that we are talking about AI. As Dr. Naveen has already said that this is the order of the day, that we have to be well versed with AI. Because not only the country, all of the world is changing with AI. And we have to be very, very careful. And we have to mention that everything is not authenticated about this very stage. So an excellent topic, and I'm sure the speakers, the panelists, all panelists will do justice to it, and all who are watching it will be benefited. Thanks, the Uttarakhand RSA, for having taken the trouble to hold it. Thank you. Thank you.
Thank you so much, sir. So with your permission, may I start the panel discussion?
Please start.
Thank you. I'll be sharing my screen now. Is my screen visible to everyone?
Yes, ma'am.
Okay, thank you so much. And welcome to today's panel discussion on ethics and governance in the application of AI for anesthetists. Artificial intelligence is no longer a futuristic luxury. It is entering our OT theaters through closed-loop drug deliveries, predictive hemodynamic monitoring, and automated risk stratification. However, as an anesthetist, we practice in high-stakes, zero-error environment, and in split seconds, we make decisions about life and death. This reality forces us to confront heavy ethical and legal dilemmas. As educators and senior leaders, we must ask how to navigate a black box machine whose internal logic is hidden. How do we safeguard our diverse Indian population? How has AI radically transformed the academics in medicine? So for our residents and faculty guides, generative academic plagiarism, all while the NMC is intensifying its scrutiny on thesis integrity. Layered over all this is the India DPDP Act of 2023, which introduces strict penalties for data mismanagement and fundamentally changing the medico-legal landscape for institutional departments and private practitioners. In the next hour, my team of esteemed panelists and distinguished senior faculty will dissect these challenges. They will provide actionable, ethical roadmap that bridges the academic guidelines with the sharp daily realities of clinical practice. So I now take this opportunity to introduce my faculty with you. So this is how artificial intelligence is coming in a very big way. For pre-operative assessment, we are using it. For intraoperative, for automated drug deliveries, for analyzing any complications which may occur. The robotic airway management is coming up for the regional anesthesia and in intensive care. In fact, the OT schedules are now being made according to the AI, with the AI help. So my first panelist today is Dr. Bhavna Gupta. She's Associate Professor in the Department of Anesthesia, AIIMS Rishikesh. Her area of interest is oncoanesthesia, airway management, artificial intelligence in healthcare, and research and innovation. She's on the editorial board of India IJ and Peak, an editorial member of Yearbook of Anesthesia. She's the recipient of Dr. KPR Award, Young Anesthetist Award in 2024, Dr. P.K. Singh Young Anesthetist Award, 2024 ISA Young Talent Award, 2025 First Prize National ISA Competition. She was the best student and has received Captain Bhattacharya Award, Hari Mir Chandani Silver Medal, and Archie Brain Award for the best paper. She has more than 200 publications in the peer-reviewed national and international journals and has author of 3 textbooks. She's contributed to multiple book chapters and has grants by MIY. Our next panelist today is Dr. Devendra Kumar Prajapati, who's Associate Professor at IKD-RC ITS GUTS, Ahmedabad. His area of interest is solid organ transplant and critical care, AI in healthcare, and anesthesia for robotic surgeries. He has chaired a session in liver transplant and has attended several international and national conferences as faculty and delegate. He's a structured faculty the training of teachers by IDA, co-team member of scientific committee UVA ISACON, faculty to the AI module ISA National, and GC member in ISA Ahmedabad City branch. He's a Grand Master in Reiki and traditional healing methods and has authored around 5 publications. Our next panelist today is Dr. Kamna Kakkar. She's Assistant Professor at SGT Medical College, Gurgaon. Her area of interest is artificial intelligence in healthcare and critical care focus. She was a core organizer of National UVA ISACON 1st and 2nd, has a fellowship in IDCCM and European Diploma in Anesthesia and Intensive Care. Her posters and papers have won multiple awards, and she has 17 publications to her credit. Our next is not a doctor, but a person of repute. He is a director of artificial intelligence, Aquina Technologies, and founder of Curie Coders and CTO. He is an AI and ML leader with more than 12 years of experience, and he's currently pioneering knowledge gaps between ontologies and autonomous AI agents. He's leading end-to-end Gen AI and computer vision developments. He has delivered AI and ML solutions for government research in advances, precision, and computer vision and machine learning. He's driving the AI strategy across multiple leadership roles, and he has impacted more than 2,367 learners and has given more than 1,600 hours to this. Our last panelist is Mrs. Shivakshi Tiwari. She's co-founder and educator of Makers Lab, Dehradun, and her area of interest is robotics, IoT, and AI. She has mentored the Young Inventor Challenge Award for Thailand, coached the winner of the Colors Infinity Inventor, guided in designing self-tutor devices, and has trained more than 500 students. She's aided in inventing the Child Safety Band winner in Cyprus. She has 5 digital courses on elementary robotics at international levels. So this is my eminent faculty, and we'll straight away start with the questioning them without wasting any time. My first question is to Mahesh, Mr. Mahesh and Ms. Shivakshi both. What is the black box? Can you explain it in simple words about black box?
Okay, thanks, Parul. Thanks for the great introduction and everything. So, see, black box in itself is a very technical term to start with. The idea over here is like there are two ways to explain it. One is going to be very much theoretical, like the pioneers of machine learning and AI themselves are unable to understand or basically figure out how exactly the outputs which we are getting for any kind of neural networks or deep learning or AI at the end of the day we are getting. So, for example, we can provide some inputs from one side. Let's take a very basic example. So, I can have an input more or less. Let's say I'm having a CT scans or an MRI or an X-ray, right? And your AI is supposedly going to tell us that, hey, because you provided me these values, I'm more or less detecting that the person is having, let's say, a tumor, right? And that's it, right? The problem is what are actually the components or the reasoning, what are the logics, how it actually deduces that logic that the person is having a tumor. It cannot justify it. No one can justify it, right? As a doctor, you are having too many vitals, you have so many things to check upon, you have, like so many things to work upon. But as an AI, there might be a reasoning that it can be as simple as that because it ended up finding something on a CT scan which might not be that big of a deal. It actually gave you that certain results, right? And there are tons of examples for this. For example, we can have a heart disease prediction, right? I can simply provide age, BP, cholesterol, ECG, and all that stuff, and it can simply tell me that, hey, big, the person is maybe having a heart attack in upcoming future or not. But again, it cannot justify which is the major cause of it. Is it because of the lifestyle? Is it because of the cholesterol, the BP, the vitals are not telling us right, and so on and so forth? So black box in theoretical sense is a kind of understanding where whatever goes inside as a part of input cannot be justified based on whatever the internal logics are and how we are actually trying to get an output on the top of it, right? There are so many inferences, and honestly, you need bigger servers and everything just to run a very basic, like a small AI network just to get you an output. So this is more or less my take on how a black box can work upon.
Shivakshi, would you like to add something to this?
Yeah, I would like to just tell it in a very simple way that if you want to understand the black box is that the internal decision making process is hidden. So even the people who have created that algorithm will not be able to fully explain how we concluded or how we reached to a specific conclusion. So any AI system which gives us an answer or recommendation, but the internal decision making is hidden from us, and we're not able to, conclude that how we arrived to that specific conclusion. That is black box. That's my take on that.
Right. Thank you so much, Shivakshi, for making it so simple. So these are some of the tools which have been designed with the help of AI. Now, Bhavna, my question to you is that as clinicians, हमने सारी जिंदगी यही सीखा है कि look at the patient, look at the surgical site, watch for the visual cues. We have to make our physiology very strong. So what is the minimum standard of evidence you personally demand before allowing an unexplainable AI algorithm to guide patient care in your OT?
Wow, that's a very brilliant question, ma'am, which you have put forth. Actually, as rightly has been explained by Mahesh and Shivakshi, that we are actually dealing with black box phenomena, where we get the prediction, we get the output, where it says very brilliantly that the hypotension prediction in this particular case would be 15%. Now, it depends on us whether we should rely on that decision or whether we should ignore it. So, being anesthesiologists, we are well aware that we have to actually legally and ethically be responsible to our patients. We cannot just rely on one prediction or one black box phenomenon in which we are actually not sure how it has actually predicted everything out. So, if I have to actually bring in that black box AI algorithm in my OT from tomorrow, I would actually ask for many things. I would ask and demand an evidence not only from the retrospective analysis, but from the prospective data. Many of the black box may have been fed with the data from the Western population. What about our Indian scenario? We deal with so many physiology, we deal with moderate anemic patients, we deal with so emergent conditions, we have so variety of cases. Would we actually trust that black box in our OT, which has been trained on the Western data? I think everybody would agree that we need more studies which are valid in our scenarios. I would highlight one very interesting study which was just published in 2025, where they had evaluated many large language models in generating the anesthesia plan for the surgery. So, as has rightly been said, it predicted very well for the ASA 1 and 2 classification of the patient. But when it came to the complexity of the cases, again, it could not predict that much. Then also, I would highlight one more thing, that we deal with so many patient data, we deal with so many crisis situations in the OT, where real-time management of the patient is the crux of the situation. This black box should provide me decision within seconds. This black box should change my decision with beat to beat variations in my patient's hemodynamics. Then again, it should provide me the real-time functionality. And not to be forgotten, also WHO highlights it that human in the loop is very much essential. AI can be our co-pilot, but we as humans should make the decision in assessing or in predicting whatever we get out of AI. So just to recapitulate everything, I would say we need more prospective studies if we are bringing those AI models into our OT. We need more Indian data, and also we need human in the loop system with real-time integration and more visual cues to get into the diagnosis. Hope that
In
answers my
addition to,
query.
Yeah.
yeah, I will just like to add something with the what Dr. Bhavna has said. See, the idea is whenever we are talking about the real-time analysis of anything, right? With all the LLMs, which is probably out there, any kind of a GPT model or any kind of a model which you can suggest, right? There is a good chances that it probably don't have enough features or enough data points to be trained upon, right?
Right.
When you are in an OT and when you are actually looking for a real time, so you are having probably tons of vitals which is going on with every possible passing microsecond. And for an AI, right, speed is
Right.
not the bigger issue because we are having servers and we are having everything. But the bigger challenge is maybe my model is seeing certain thing for the first time. If that happens, the model, as we already discussed, as it is a black box, it really don't have a clue about it. So for example, if let's say my heartbeats move from 120 to 180, probably that is a data set which my model skipped while it's being trained upon, right? So when it happens, it is supposed to give you a wrong result as well. So when we are thinking something from an OT's perspective where the risk is very high, there are more pointers and there is a more need of human loop to be present over there so that we are not, like everything should go in a right way or the right direction.
Right. So moving on to the next question. Kamna, this question is for you. I think you are millennial, you are generation millennial, but you are now training new students also, and these students are more, comfortable with the screen. अब हम पहले ही कहते थे कि ये जो जनरेशन है वो पेशेंट को नहीं देखती है, मशीन के या मॉनिटर्स पे देखती है. So how do you think we should train these new students about using predictive AI without letting them fall into this automation bias? कि जहां पे वो ब्लाइंडली मॉनिटर्स को ट्रस्ट करें और पेशेंट की तरफ देखना ही बंद कर दें.
Thank you, Parul ma'am, for this very interesting question. So, ma'am, the first thing that comes to my mind when I hear this question is that you can't let Gen Zs, you can't let them stay away from the screens. There is no way that they are going to just let go of their habits. So we have to accept that we have to train the modern anesthetists, the youngsters, in AI. We can't let them just play with AI. We have to teach them how to use AI responsibly and ethically. So I think the whole crux of our whole discussion today is on this only. So first of all, what I personally like to do is teach them how to use it. So the thing that I teach them is to challenge AI. You just don't believe in whatever the screen is saying. You ask them, do you think this is right? Do you think what AI is telling you is right? So suppose if AI is some AI algorithm is telling them that the patient is going to have hypertension in the next 5 minutes. So I asked them, do you think AI is correct here? Why do you think AI is correct here? So I asked them to critically evaluate all the present information that they have about the patient, including the condition of the patient, the vitals, whatever the data that they have in front of their screens. I asked them, spinal ka level kitta hai? How much fluid have you preloaded? All those questions which are clinically relevant. And then I asked them, do you think what AI is telling you is right? So until and unless they know how to challenge AI, they will not, they will not learn how to use it responsibly. So AI is not going to be the decision maker for them. They are going to be independent decision makers in their life, and AI is just going to assist them in clinical decision making. So AI can't replace anesthetists anytime soon. This is something that they have to, you know, get it into their heads. And we as teachers, we are responsible for doing simulation trainings. Ask them, where is AI wrong? Where is AI correct? Where are you both correct? Where are you both wrong? So critical thinking develop. We have to, develop critical thinking skills in anesthetists, in the youngsters. We can't let them blindly trust the monitor. So this has to be part of the training, simulation skills in AI.
So next question goes to Devender. Devender, when there is a private practitioner की बात करें अगर हम, he faces a conflict in the OT theater between their clinical instinct. Oh yes, the blood pressure is going down, or the patient is, not good, and a black box AI recommendation. So what protocol do you advise they follow to protect both the patient and their own professional standing?
Yes, ma'am. So it's a very good question. Basically, because of as an anesthesiologist, we always do believe in safety first than anything else. So to me, AI should be treated as a decision support tool, not a independent decision maker. So responsibility, final responsibility should be on us only. So, see, if you ask me about operating room protocol, then again, always I will tell the like we should put patient safety first. I mean, in suppose in a case of emergency, you should not delay the treatment while trying to understand the AI recommendation, right? And again, always all our panelists and esteemed faculty will definitely agree to this. Like we should verify the output given by the AI before trusting them. Then always like Kamna ma'am and Bana ma'am has already put an pressure on that, like we should apply our own clinical judgment. Then again, we should go for a second opinion when feasible. I mean, we should go to a senior person or anyone who is available at that time. And the most important thing to me is it should be documented and reported for further learning of that AI model. So, like clinician is always an accountable for this, and AI is always an assistive to us. So, like you should use AI as a co-pilot, not an autopilot mode.
Right. So after this discussion, I've come to a conclusion that AI is strictly an accessory tool and it is not a replacement for clinical acumen. Like physical patient assessment, like capillary filling, chest rise, surgical field inspection, they all always trump over the screen metrics. I think all my panelists agree with this also. So Kamna, there's a question for you कि आपका एक स्टूडेंट है, उसने AI ने प्रिडिक्ट किया कि हाइपरटेंशन होने वाला है एंड उसने उसको ओवरराइड किया कि नहीं अभी पेशेंट इज लुकिंग स्टेबल and it turns out to be that AI is correct. So how do you handle that in the post-operative audit? And do you penalize the deviation or you praise the autonomy of your student?
Thank you for the question, ma'am. I think in a scenario like this where the AI is telling you that the patient is going to have hypotension, and the doctor on duty, the junior doctor anesthetist on duty, feels that the AI is wrong. So I think I would appreciate that they are using their own brains, that they are using their own critical thinking skills in evaluating the condition of the patient. But at the same time, if the AI turns out to be correct, suppose the patient actually develops hypertension and the PG was wrong. So in that scenario, we have to not penalize the PG, but instead we have to estimate where the PG went wrong, where was his critical thinking ability wrong, where was his competence challenged by AI. So both ways we have to see if the PG was reckless in ignoring repeated alarms by the monitor, if the PG was reckless or not, or if the PG he ignored the warnings multiple times, did not take a second opinion, did not call for help at the right time. At that time, the young anesthetist has to be mentored and taught about the clinical skills where he lacks. But if he is using his brain to override AI prediction, then I think that should be appreciated as well, because Of course, what we are telling right now is the same thing, that we are the ultimate decision makers. The entire medical legal responsibility of the patient lies on us, not on the AI tool, right? So if he's using his own brain, I think we should appreciate that. But if he is wrong in using his own brain, we have to correct him. Parul ma'am? I think I have made myself clear, ma'am.
Yeah. Am I audible now?
Yes, ma'am.
Yeah.
Yes,
Yep.
ma'am.
Right. Actually, the electricity has gone down, so I was
Oh.
on a fix. So, what I personally feel is that a post-operative audit is basically a teaching tool. We have to
Yeah.
discuss with our student what has gone wrong, how it could have been corrected, and I totally agree with what you are saying, Kamna. Bhavna, according to this scenario, if the AI predicts an event in 10 minutes, but the patient looks perfectly stable to you, what is the ethical threshold for initiating treatment preemptively?
Oh, that is a very interesting question you have put again, ma'am. Actually, here the dilemma would be whether to go with that prediction, because actually what AI makes is only a prediction. It cannot actually confute a diagnosis. So here I would actually like to give an example. Suppose we are dealing with a case of laparoscopic colectomy. The patient seems very stable right now. All the vitals are stable. Capnography looks fine, and the surgical field. Sorry, am I audible?
Yes, you're
Yes,
audible.
ma'am.
Okay, sorry. And the surgical field is dry enough. And suddenly the AI monitor flashes in front of my eyes saying high probability of hypotension within 10 minutes. Address it. So, what will you actually do in that scenario? Would you immediately give fluids? Would you immediately give any kind of inotropes? I think most of us would say no, because this is just a prediction. It is a probability statement. What AI is telling to me is according to the patterns he has seen before, what according to the pattern it has been trained on. It has been trained on millions of data, and it is just telling me that my patient has a higher chance of going into hypotension. Now, here as clinician, we would actually go one step further on. We would actually see whether this prediction actually matters to us. Here, I would actually go around and see the patient field. Everything seems fine, and I can just ignore that alarm for now. But I can be vigilant enough if I see something is missing, and I can be more alert regarding other things. So, regarding such scenarios, if prediction is made by AI, how should we actually handle this scenario? So, this can be dealt with in the scenario that if it has made a prediction which according to you also is accurate, and intervention is low enough which we can take the decision, I think we should go with the AI prediction. If the prediction made is absolutely wrong, then we should ignore those predictions.
Okay. So the take-home message is that yes, we have to use it as a lot carefully and with the clinical acumen. So coming
Right,
over to
ma'am.
the next section is algorithmic bias and medical equity in Indian population. What you were talking about bias. So Mahesh, my question, and this is for you also, Shivakshi, that moving from how algorithms think to what they learn from, that is the most commercial AI is trained on the Western database. So what are the bias which we actually face in Indian population?
See, in that case, there could be a lot of instances because majority of the models are Western. Like Western countries have actually a monopoly in creating those models. Of course, all the biases goes towards them. For example, I can tell you a couple of things. The culture bias which we are having in India versus what we are having in Western is entirely different. Out of which our lifestyle is one of the biggest factors, right? So we are having a different lifestyle, they're having a different lifestyle. And while coming across any kind of a prediction, any kind of forecasting, any kind of an output, right? AI model is always going towards the bias, like how Western lifestyle has been, right? Same goes with our like the skin colors, right? We are a little bit on a different side, they're on a different side. So the way our body is going to react to certain things, their body might not be, right? And there are like enough instances. The problem with this thing is because Western guys are the one who has this, so the majority of data, there are, let's say, 10 million data points, or there are 10 million inputs on which the model is trying to be trained, probably we are just contributing by 1,000, right? Which is a lot less as opposed to what you might imagine. Another thing which is pretty dominant over here is our language, right? In our case, right, like, of course, English is not our first language. So we are having our local language, probably Hindi is something which you would like to speak in, or probably we are having our local slangs and everything, right? So while we are having our conversations, while we are in OT, while we are trying to do certain things, we are trying to get certain results out, right? There is a good scenario that what we are trying to convey to a given AI, that might not be how it's going to be reflected at the end of the day. Because even a single word referencing here and there can change the entire output, right? So Western data bias is extremely on the like a different scale altogether. Can we do something in order to balance it? Yes, we can do. So in that case, I would take the previous comments from Dr. Bhavna and Dr. Kamna, and that is, until unless we are not going to keep regressive questions and coming to an AI, it's not going to give answers what we are actually looking for. It is always going to be biased towards one end or the another end. So this is something which is always going to be the case until unless there is a local model which we developed, or let's say probably you doctors ended up contributing towards and create a very custom model for yourself. But the models are going to be biased and we don't have choice over here.
Shivakshi, would you like to add something to what Mahesha said?
Yes, ma'am. So I would like to tell you that as Sir also said, that Indian patients are often having different body types and baseline hemoglobin levels are different. Local health conditions we have very different in India as compared to the Western society. So the AI that is not trained for Indian data can always misread what is normal for maybe Indian patient vitals could be read as abnormal, right? Because it is trained with the Western data points. So that is what we are concluding right now, that AI is always a second opinion and not the first opinion, because it has biasness and it's been trained with the it's been trained with the Western data points.
So these are some case studies which have, these are the real world examples of AI bias and consequences. So moving on to the next question to Devender. What specific physiological variations in Indian patients are most at risk of being misread by biased global AI modules?
Yes. Thanks, ma'am. It's again an excellent ethics and governance question because it highlights the danger of data bias. So I would say AI is only as good as the data it is trained on. If the Indian patients are underrepresented in their training data, which is usually the case, normal variations seen in our population may be incorrectly flagged as abnormal, while genuine risk may be missed. Previously, our panelists also highlighted that about hemoglobin levels, right? So specifically in Indian women, there is low baseline hemoglobin levels. So AI may overestimate perioperative risk also. It may recommend unnecessary transfusion or investigation. We may have be on BMI different body propositions, like body compositions are different. So AI model based on Western BMI threshold may underestimate metabolic or cardiovascular risk. Even in India, we have higher prevalence of diabetes and metabolic syndrome that may AI may not fully account for the earlier onset and different progression patterns in Indian patients. And classic examples of tropical and infectious disease like dengue and malaria. So AI trained on data sets from high income countries or Western countries may not recognize this disease as important contributors to the thrombocytopenia, coagulopathy, or fever or any organ dysfunction. And sometimes in chronic nutritional deficiency, which in Indian population we are seeing iron deficiency, vitamin B12 or folate deficiency. So lab abnormalities may be misinterpreted in that way. So AI model, to conclude, I would like to tell that AI model validated in London or Boston is not automatically valid in Lucknow, Ahmedabad or Chennai. So we should train our own AI model for specific to our population.
So Devender, you can say it is Videshi hatao, Swadeshi lekar aao, right?
Yes, ma'am. Yes, definitely.
So Bhavna, coming over to you, you're working
Yes,
in a
ma'am.
premier institute. So do you think that these medical institutes, they should mandate a localized validation, right? May I
Definitely.
request the audience to kindly mute themselves? We can ask you, you can ask your questions later on. So, Bhavna, do you think that these high institutes, they should mandate a localized validation trial before commercial clinical AI software is cleared for use in the ORs? Because you have the
Definitely, ma'am.
facilities, you have the infrastructure, so you can check these softwares and then you can say that, yes, you can use these softwares in the OTs now.
Definitely, ma'am. I totally agree with you. These AI softwares, they are nothing but equivalent to medical devices according to CDCSO guidelines. CDCSO is nothing but the Central Drug Standards of Organization, which formally classifies AI as grade C medical devices equivalent to CT scan. So, as you have rightly pointed, there must be validated studies, because we have all highlighted and actually got to the point that Indian population is different from the Western population, and we cannot use the same validated tools which were validated in the Western population in our Indian scenario. So again, here I would like to highlight one more thing, that the AI softwares, there are definite validated platforms which are available where we can actually validate these tools. There are guidelines also which are issued by WHO, by CDCSO, and other higher authorities, that we must validate our findings in the Indian population. Now, coming to validation, how they must be done. Here, I'm not talking about that we should spend crores of rupees for validation of these softwares. We can do something much simpler validation, which is in a form of shadow mode, which they say as the method to be. What is actually shadow mode is, here the AI model will also predict some kind of prediction analysis, like for example, hypotension prediction or airway difficulty or any missed alarm prediction. So the doctors are doing their job. AI is also doing the job in the background, and then they see the studies that how many false positives or false negatives arose as a basis of those tools. So there are various platforms in the form of like both, that is benchmarking open data platform that has been established by IIT Kanpur, where they provide anonymous Indian health data, and we can also validate some of our tools according to those modules. And also, as many guidelines by ICMR, they also highlight the fact that human in the loop should remain in those studies, so that it becomes more imperative for us to actually go with the decision which are made by AI.
Right. So my next question is to Mahesh. Mahesh, there's an advanced AI tools जितने भी आएंगे, ये corporate hospitals में आएंगे. Do you agree? Because of the cost, they'll be first hit into the corporate hospitals. So how can we prevent this digital divide? जहाँ पे public sectors, residents, rural patients ये पीछे रह जाएंगे और advanced hospitals या बड़े hospitals ज़्यादा कामयाब होंगे.
Dr. Parul, I think your voice is echoing. Is your sound on in some other device?
नहीं और तो कोई device नहीं है.
Your voice is echoing, ma'am.
Now is it clear?
Yes, ma'am.
Yes, ma'am. Can you repeat the question, ma'am?
Yeah, sure. Mahesh, this question is for you basically. I want to know that these AI tools, they'll first come and hit onto the corporate hospital because of the expenditure. So एक divide आ
True.
जाएगा, digital divide between the corporate hospitals and the government hospitals, residents and rural patients. So how can we, prevent this divide?
And see, that's a very fair statement that like corporate hospitals are going to get first access of these things. In fact, if you look around, all the corporate hospitals have somehow, started the trial of all of these AI assisted diagnosis and everything. In fact, in the field of radiology, majority of the predictions are coming from the AI. Of course, doctors are giving their inputs and they are like overpowering this thing for the time being, but this is what the current scenario is. And the biggest factor is the amount of money which is involved and the finance which is involved from the corporate sectors as opposed to like the public sectors which we are having. So essentially, just to prevent, what I can suggest, there are a couple of things which we may do at this moment. This is just probably the suggestions from my side. The first thing which we can do at the moment is to probably do an early, like pilot projects in the public sectors, probably in your district hospitals, your government medical colleges, your rural hospitals, right? Your small clinics, so that at least everyone can be get onboarded on these things and they can start, expediting and working in this sector. Right. Second thing, something which Dr. Bhavna has already stated. In fact, this is something which is very common in the Western countries, but sadly not common in India. And that is having a centralized infrastructure, having a centralized, I would say, a database where all the doctors are continuously, like improving the inputs and giving the feedbacks, and our database in itself is evolving at a good stage, right? Because eventually AI is governed with the data. If you are not having data and if you are keep on relying on whatever is being provided from different sets of world, then of course it is not going to be custom to our values. So to make it much more feasible and affordable even for the public sectors, I think if we can have something like a shared AI infrastructure, it could be something like an initiative from IIT Kanpur. In fact, I think there is another initiative from IIT Delhi as well. There are these incubator centers which are trying to create some shared infra where doctors are, actively providing their inputs, their data sets. They are sharing some of the feedbacks or some of the what you call details of patient under certain governance and the guidelines. So that could be another thing which we can do in this case. Another interesting thing which we can do is if we somehow can add the local data inclusions, right? So, for example, our own people, right? Like the way we are actually having our lifestyle, our working conditions, our medical health conditions, right? Like what are the local diseases? What is the most common form of disease which we are having in our country, right? The idea is how much we can customize that and how much we can make it accessible so that other people's, and it can be, like instead of, involving a whole lot of money, even the public sector should be able to afford it. So these are a couple of things which we can do. In fact, there are some low cost AI tools as well, which you guys can probably work with. For example, we can start doing mobile based training, right? We can start working with small AI models, not like on a GPT scale, but probably a small model which might be sitting on your smartphone. You can take, let's say, a scans or something, and you can start deducing on these things. So if we are trying to do all of these things, then definitely it will a good step in terms of preventing AI, in terms of just going towards the corporate, not to the public sector.
Right.
That's my take on this.
Can I chip in something?
Please, Shivakshi.
Sure.
So if, government subsidize some medical AI software that is aimed specifically for some public, medical college, so that will give a level playing field and there won't be that digital divide that ma'am is talking, that commercial hospitals could be the first one to adopt everything and the, interior and rural hospitals, government hospitals will lag behind. So the role of the government is major here also. Thank you.
Right.
Right.
So हम इसी क्वेश्चन को प्राइवेट प्रैक्टिशनर्स के उसमें लेते हैं. Devendra and Kamna, this is for both of you. I would like to know, how can a single specialty nursing home validate an imported AI monitor without the lakhs of research budget of a tertiary care hospital? मतलब tertiary care hospitals के पास तो budget ही है और एक छोटे nursing home के पास नहीं है या एक छोटे hospital के पास नहीं है. So how can, they tide over this, or how can they, validate their requirement for an AI monitor?
Thank you for the question, ma'am. Right now, currently, if you ask me, no AI model is ready to be implemented in small scale nursing homes in India right now. Reason being, right now there is no data available for external validation. Very little studies are available on Indian population, let alone population in suppose a rural Haryana hospital, right? A tiny nursing home in a rural area of Haryana. There will be hardly any data available to validate the algorithm that is being used in that AI model. Thirdly, we don't know what the sensitivity of that algorithm is, what is the specificity, what are the false positive, what are the false negative rates of that device that is being given to us by the vendor. So all these things have to be asked from the vendor who is giving us the device, that how many studies have been published on this device, what you are giving us in a nursing home, how many peer-reviewed articles have been written on this, whatever algorithm that you are using in your device. Will it be updated anytime soon? Because every day AI is changing, AI models are changing. So how frequently will we be getting the updates in that model? So all these things have to be asked from the vendor. Secondly, in that nursing home, we can, like what I did in my hospital was we started our own studies. So, we can run AI machines in the background and use our conventional, whatever clinical skills along with that device, just like Dr. Bhavna told. We can do our own studies. We can, calculate our own sensitivity, specificities, uh, compare the outcomes that are given by AI machines and compare it with clinical decisions that are being taken by professionals. So when you compare both these things, then only we can do. So in small nursing homes, you can, do pilot studies of 100 to 200 patients and uh, do your own basically validation of that algorithm, of that AI algorithm before you implement it. Then thirdly, we have to train our you know our doctors, our nurses, everybody has to be trained that you don't have to trust AI. You have to
Trust it.
critically evaluate what AI is telling you. So
Right.
all these things together maybe can help us implement these machines in smaller nursing homes. So this is what I feel. If Dr. Devendra has something to say, sir.
Yes, ma'am. Everything has been covered. Actually, see again I will just speak briefly. I mean, always we should verify the output. I mean, vendor तो अपने पास आ जाएगा. He will tell everything. Everything is good. So first we should in a small nursing home we should run our own as already ma'am said our own study, and first we should run it in a silent mode, in a background mode, and we should verify ourselves and then go ahead with that particular AI model, or I mean AI model. Yes, that's it.
Right. So now let's pivot towards academics and use of AI in research. So Bhavna, my question is to you that AI has completely disrupted the traditional thesis process. We used to go to the libraries, look for the articles, get them printed, and then search what we wanted from these articles. Now, as your thesis guide, where do you draw an absolute ethical boundary between using AI as a grammar check versus how to write your literature review or manipulate the data?
Wow, ma'am, that is a very actually interesting question which you have put. And this is actually, we all are facing it. We are also not aware that which person is using which tool and coming out with their academic performance. And we actually can't predict that whether it is their own ideas or whether it has been brought via the help of AI. So, coming to your question, like you have asked, where do I draw the ethical boundary? So, the ethical boundary is drawn at the topic itself. Even people are getting the ideas from the AI, and it is not about only using AI, how they are using it, and where all they are using it. And many, interestingly, many big societies like UGC or the AICTC or ICMR guidelines, they have come out with very strict regulation regarding the PhD thesis, and where they have actually given penalty for the use of plagiarism or AI in the use of thesis for their candidates. And even cancellation of registration has been done. You can Google a few of those reports. It is there in the Google. And coming to the ethical boundary, where we actually set that boundary, as long as if person is using AI for the clinical polishing of the grammar, like we all agree that coming from India or the developing countries, we people are not very well versed with the English literature, and people can make the use of AI, and we have been using that previously also before the advent of these AI tools. People have been using Grammarly or the Quillbot or for Paraphraser or other such tools. Now with these advent of AI generation, the ball game has totally changed. So people are not just using it for the language or the readability check; they're using it verbatim for generation of the entire thesis, and not just the thesis, the entire data is synthesized from the AI, and also the discussion entirely is written with the help of AI. The stats is entirely written with the help of AI. So that boundary is totally the author's misconduct, and it is not just the author's discretion, but also the guide is equally responsible, because we have to guide our students that how they have to make the use of AI tools. in their thesis writing.
Right. So, Devendra, continuing with this, we all know that NMC has, become very strict with the conducting the research with integrity and with correct steps and everything. So, what do you think, should an institute review board or ethical committee of a particular institute or the thesis guide use to audit and verify that a resident's raw data is authentic and not synthetically generated by the AI? How can you
Yes, ma'am.
make sure that your resident has not, used AI for the raw data?
Yes, ma'am. So this is very relevant governance and ethical question as far as research work is concerned. So I would say the goal should not be detect AI generated fraud after the thesis is completed, but we should focus on to build systems that make fabrication difficult and traceable from the beginning. So I would suggest for institutional review boards or such committees, they should demand source data, not just Excel sheets. So you may ask your resident to preserve original case record forms, even anesthesia chart, monitor screenshot whenever applicable, even lab reports and electronic medical records. So fabricated spreadsheet is easy to create, but authentic source document are much harder to fake consistently. You may go for random audits. I mean, they can randomly select up to 10 to 15% of enrolled patient and verify for like hospitalization number, whether the student has taken consent form or not, operative notes about anesthesia records, lab values, whatever he or she has entered. Then see, prospective registration of study is already a mandatory step that will help a lot. And we should go for like forensics of statistics, as already Bhavana ma'am has highlighted that nowadays students do use of AI for stats also. So for that, biostatistician can identify suspicious pattern, if it is excessively perfect distribution, unnatural, low variability, all that. So these are the few steps these committees should focus on.
Right. So, Kamna, this is for you. आपका रेजिडेंट ने थीसिस कंप्लीट कर दी, उसने सबमिट भी कर दी, बट सबमिट करते वक्त उसने गलती कर दी कि एक रेफरेंस उसने फैब्रिकेटेड यूज कर लिया. That was a AI generated hallucination, a completely fabricated journal citation. So who ultimately bears the ethical and professional liability? The resident or the faculty guide who has signed off the thesis?
Whoever is mentioned as the author is responsible, equally responsible. The guide definitely has to oversee the research work from A to Z. The guide is responsible for the research conduct of the student, but whoever is listed as the author is ultimately responsible. So obviously, if a reference, we can't check, like if there are 100 references in a thesis, you can't individually check each reference, right? But what we can do is we can ask the student to get, suppose, get all the articles. Give me if the student can download the article and show it to me, I will say yes, the reference is correct. But if they can't, so obviously this is the work of the guide to check if all the work done by the student is legitimate or not. So Mango, we have to ask them. He'd get us all the articles. If they're able to download it, then obviously the references are correct.
Yeah, and we have softwares where like Mendeley is there.
Yes, there are softwares to
Softwares
detect.
bhi hai,
Yes.
which the article, the moment you click on, the original article will open. So
Yes.
you can even get used to all these
Yes,
things.
yes, yes. The
Yeah.
source should be identified.
The source
If they
should be
can't.
identified. I agree with that.
Because hallucination is something that is well known by by ChatGPT, by all these. They hallucinate. Even till date, they are hallucinating references.
So Bhavna, you are on IJ editorial board. Is these medical journals, they're rapidly adopting strict AI disclosure policies. So do we have some disclosure policies at IJ, or do you foresee a future where we have to, explicitly list the AI tools which the person has used in his thesis or in his article publication?
Definitely, ma'am. IJ holds zero tolerance for the use of AI. Even if you see the IJ homepage, there is a specific first page template which is available for the authors to sign in whenever they are submitting their thesis work or whenever they're submitting any case reports or letters to editors. There's a clear disclosure which is written in the IJ template that you have to disclose the use of AI. Here, the use of AI is not just the use of AI, that how they have used it, in what manner they have used it, if they've used tools just for grammar check, if they've used tools for the synthesis of the data, if they use tools for image generation, if they've used tool for the discussion interpretation, or if they've used tool for fabrication of references, everything has to be listed. Why it is essential? Because in biomedical research, we want reproducibility, we want transparency, and we want accountability. So to addressing all these facts, IJ is very strict about the use of AI. We are getting too many AI generated text articles, which we have to reject them because it is not the author's own ideas. It is it is almost like 100% is AI generated text we are getting in IJ.
Okay. So even JOACP, they have these AI tools. You have to declare your AI plagiarism there.
Right, ma'am. Right, ma'am.
So my next question is that Devender, if a resident has used ChatGPT strictly for, last sentence है कोई discussion में उसका sentence framing ठीक नहीं हुआ and he's used ChatGPT का help लिया है उसने. So is that acceptable editing aid or is it ethically a violation that needs a disclosure?
I'm using ChatGPT like solely to improve grammar, sentence structure, or readability is generally considered an acceptable editing aid, not research misconduct. But however, transparency is the safest approach, and authors should comply with the journals and institutions' disclosure policies. So I mean, AI can help with how you write, but not with what you conclude in your research work. So
Right. So
like correcting grammar, improving sentence flow, all are acceptable uses.
So it is something like a human proofreader. As a proofreader, you
Proofreader,
can
yes.
use a
Professional.
ChatGPT.
Yes, ma'am.
And not as a, something who is generating a data for you. So my last question in this section is for you, Bhavna, that NMC is increasingly strict about the research fraud. If a student fabricates statistical data using generative AI, does the institution blame stops with the student, or are we as guide legally and professionally complicit of signing off?
Ma'am, this is definitely a case of outright misconduct. There's actually no difference between if he has been doing it manually or he's using AI to fabricate the data. The seriousness remains the same. If the student is actually fabricating the entire data, he is liable and he is clinically responsible for the same. But at the same time, the guide who signed off the thesis without accurately identifying all the lacunae is also professionally in the same crime. So I think we need to be very vigilant whenever we are seeing the thesis of our candidates. We need to check the raw data. We need to check how they have made the analysis. We actually need to verify whether it is AI generated statistical analysis or something suspicious. We can look that how he has written the entire thesis, whether he is able to explain the concepts entirely or in toto. We need to be very vigilant before signing off.
Right. So I'll move on to the last section of this panel discussion, and that is the DPDP Act, which safeguards the patient confidentiality and ensures the compliance with legal and ethical standards. And as we are running short of time, I'll be very quick, and I would request you to keep your answers short and crisp. So why clinicians should take care of this? Because we are sharing information of the patients on WhatsApp. Cloud-based documentation apps are being considered. We are sending image for a second opinion to someone. We are using digital consent forms. We are taking copies of patient details into an AI tool, and we are storing the patient data onto a personal device. So my question for you is, Mahesh, is that what advice do you have for doctors on legally streaming patient vitals into a third-party cloud-based AI software without committing a data breach?
See, first of all, the idea is you have to basically figure out where exactly it's going to be a little bit technical, but where exactly the end servers are being placed. Is it an India-based servers or is it like Western countries-based servers? So, for example, the Zoom stream which we are trying to have right now, all the content is probably routed via America or some European countries or whatever, right? So the biggest question over here is whenever we are trying to trust on any third-party softwares, is where exactly is data is going to be stored? A. B is, are the hospitals having enough infrastructure that they can hold the data locally within the hospital? Maybe the data is not living anywhere else. That's the second part, right? The third part is when doctor is trying to share the data, like are they sharing the minimum data? For example, if they are trying to share the data, is it just the vitals? For example, it could be BP, pulse, it could be some SpO2, some heart rates, whatever, right? But are they also trying to pass something unnecessary like their name, their phone numbers, Aadhaar cards, or any credentials, any details in regards to that, right? Are they trying to pass any kind of their credentials at the time when they're passing the data? So, for example, instead of saying that, hey, Mahesh is having some XYZ thing, can I simply refer it as patient 123 is having some XYZ thing? Because that way I'm just sharing the data, which might be, even if it's processed, it's just a symptom or it will be helping me to predict something, but it is not going to associate with the end XYZ patient or whatever, right? So that is another case. Are the vendors under some legal entity? Like, are they legally void to do something, right? Like, have they proper security certifications? Are they inside? Have they verified the DPDP Act, right? Are they in the compliances with this or that or versus something else, right? Are they have performed any kind of encryptions? His data is just simply shared with, for example, is Mahesh is going end to end as Mahesh, or is Dr. Bhavna is going end to end as Dr. Bhavna, or is it being referred with some another name, let's say patient 123 or whatever, right? So the idea over here is whenever a doctor is trying to share a data from their third party application to anything else, how exactly the data is being processed, what kind of legal entities the application has followed, how the institution strictly followed those instructions, everything should be taken into account. And then only a third party application should be introduced inside the premises in the first place. That is how it should start getting inside the picture.
Right.
Can I also?
Yeah, Shivakshi.
Yes, ma'am. So according to the DPDT Act 2023, you have to get the clear and specific consent from the patient before sharing their data.
Yep.
To any AI software. So you have to tell them that we are going to share your data, and you have to make their data only, like you have to strip off their all person, like sir said, all the personal information that is identifiable information. So it has to be only physiological numbers, like only the BP
Yep.
or the oxygen levels. So this and the yes.
In fact, I would just add to the Shivakshi that you have to actually tell your patients as well, like how much data you are planning to share in the first place, right? And they have to be agreed upon that. Like, for example, maybe they are not comfortable sharing their ECG vitals or whatever, right? So you have to let them know in advance that, hey, we are going to, or we are planning to use this data of yours. Are you comfortable in that? If yes, then why not? If not, you can't do that, like irrespective of
Exactly.
the application demands, right?
Okay, so we'll move on to the next question, and this is for Bhavna. We know this, that DPDP Act mandates that the consent must be specific and unconditional. There's no two things about it. So, अगर कोई emergency trauma होता है या crash LSCS case होता है, how can we ensure ethically and legally कि ये consent हमने ली है और उसका data हम patient का retrospective research के लिए use कर सकते हैं या predictive AI systems के लिए use कर सकते हैं?
Ma'am, actually, this is a exception in the DPDP Act, which specifically address this kind of medical emergency where we are actually dealing with trauma patient or emergency crashing patient or any cesarean patient where both the mother's and the fetal life can be at risk. Why it is an emergency scenario? Because they say the DPDP Act says that both the patient is not in a condition to give a very valid consent. So during that time, you can use the data, you can go through the investigations, you can actually go and check with the AI models if they're available. But once the patient is shifted to the post-operative room or in the ICU setting in which the patient has actually gained the consciousness, it becomes your legal right to take the consent in the most lawful manner from the patient.
Bhavna, would you like to add something to this?
Ma'am, irrespective of that, if it's elective or emergency or whatever, consent has to be taken if we are going to use the data of the patient. So if you take it today, well and good. If not, take it tomorrow.
Right. So Mahesh and Shivakshi, again, this question is for both of you. If a commercial AI anesthesia monitor suffers a catastrophic data leak or critical software failure leading to patient harm, so ये liability किसके ऊपर आएगी? Data fiduciary के ऊपर, या हॉस्पिटल एडमिनिस्ट्रेशन है जिसने सारा डेटा उनके पास है, या मल्टीनेशनल टेक्निकल डेवलपर्स के ऊपर?
Ma'am, see, in this case, the idea is like it's impossible to put one single entity accountable. Like everyone has to be a certain accountability. For example, in terms of individual consultants or anesthesiologists, right? If a doctor basically blindly, relied on some AI without, any clinical verification, like doctors have not verified, institutions have not agreed upon that, right? If there are certain abnormal patient signs and doctors still try to, just simply pursue the AI, right? If the device is not approved of certain protocols, if device is not complying with DPDPX, so individual consultants might be at fault over here. Then comes the hospital administrations. If hospitals haven't verified the AI software in the first place, all the cloud discussion which I did, all the data discussion which we did, right? If the data validation is not done in initial stages, right? So maybe hospital is also the part of it. If I talk about, like the final and, multinational tech developers or the MNCs which actually create those, so have they taken every policy, every protocol, every kind of act in their placing or not, if the data is encryption or not, if there is a failure at their application end. So for example, if I'm using some kind of, let's say, an ECG monitor, and there is a backdrop policy where it actually can send data to some other servers. So that is a fault at their MNCs end, right? So almost all the parties are accountable, but that depends upon like the breaches happened on which scale and where exactly the first POC over there. So that is how we can see it over.
Right. Shivakshi, would you like to add something to what Manisha said?
Yeah, I would like to tell one thing, that the law holds hospital primarily responsible for safeguarding the patient information. So if in case there is any data leak, right? So directly the hospital administration is accountable and the government will penalize them. So I mean, the data safety is the most important part, and the hospital is directly safeguarding that. Not even the tech developer, because whatever software you are using with the company, you have another contract with them. So their software can have a failure, and you can, as a hospital, you can sue the software developer company. But the primary stakeholder is hospital administration. So they have to be very careful.
So I think we can safely say that hospital bears a financial burden of a data breach, and it is the technical developer who has a strict product liability. Do you agree with what I say?
Agree.
Yep. So in terms of hierarchy chain, I would like to put like hospital being the priority, like it's the first, like the flag bearer in this game, like they will be held accountable, and afterwards your AI vendors, your MNCs, and then comes the doctors on individual levels if they have somehow mishandled the data or they perform to use some third-party application. So that is how the hierarchy should be over here.
Right.
Plus, ma'am, I would like to add that the onus of informing about the data leak to the patient, that your data has been leaked, is the onus is on the hospital himself. The hospital, it is the duty of the hospital to inform the patients.
Right, I agree.
And here it is important, ma'am, it should be actually told to the patients that within 72 hours of that data leakage that this has happened, and the consequences can be this. However, we have taken the safety guards to prevent for further things. And one of the things has been rightly pointed out, the accountability remains with the anesthesiologist who is dealing with the patient.
Yep.
So, yeah.
So my next question is for you, Bhavna, कि आपके पास एक पेशेंट ने आपको कंसेंट दिया इंट्राऑपरेटिव, आप उसका डेटा रिसर्च में यूज कर सकते हो, आपने उस डेटा को अपने पूल्ड AI ट्रेनिंग मॉडल में भी यूज कर लिया, बट डाउन 6 months down the line the patient says you cannot use my data. Now how do we logistically pull out of that situation?
Ma'am, this is a very tricky scenario, I would say, because here under DPDP Act, it clearly states if the patient withdraws the consent, it becomes very liable for the hospital, legally obligated, that they should stop processing immediately the personal data of the patient for the specified purpose. And for the future use, it is definitely achievable. We can delete from the repository for the further training of the model. But just imagine a scenario in which a trained model has been processed on the patient's data, including other 10,000 of the data which were held in those training model. Now, the problem which can arise now is if we delete single patient data from those training models, what will happen? We'll have to retrain the model again, and that will incur the cost and also the time in which was invested for training the model. So the practical solution which have been suggested for the institution is whenever they are using it, they should anonymize the patient data so that in case they revoke the consent later on, there is no chance that the patient identity could have been revealed. And the second thing is they are advocating for the granular consent, where if the patient withdraws for the consent, for the future, definitely it can be done. For the previous things, I think it is a gray line. Others can put more inputs to the same.
Mahesh, would you like to
Yeah,
add something to this?
yeah.
Because
So
you're a
in that
technical
case, like,
developer also.
yeah, so in this case, like I would go ahead with like what Dr. Bhavna has to say. So the idea is when you train the model, right? Like theoretically and practically, it's impossible to take out a data point over it. It's present over there. What we can do instead is first, we are not going to use that patient's or that person's data in the future. That's a mandatory thing. Second, the reason why we have all this discussion in the previous question as well, like it's been clearly stated that whenever you are training a data, right, it is irrespective of any kind of named entity recognitions for any nurse in general, right? There is no personal or credential based information which is produced over there. So practically it's an independent data point which no one can figure out, like, okay, for example, if I randomly go out and say that, hey, the SpO2 level is this and BP is this and that, out of 8 billion population on the planet Earth, it will be matching with some people, right? There will be a group of people whom the vitals will match, that's for sure, right? So the idea is if the patient says that, hey, you can't use my data, that's totally fine. We cannot use for further training. In fact, we might be just simply dropping from the existing repositories or database, but it's next to impossible to first of all pinpoint that the patient XYZ is having these data to work with. And once it's inside the system, it is essentially a 0 and 1. So practically it's impossible even for the supercomputers to pinpoint that, hey, this 0 belongs to this particular person. So it becomes a more or less and kind of a redundant topic to start for, right? So it's not going to happen. That's for sure.
Okay.
Like
Fine.
technically and theoretically, it's not possible.
Okay. So my final question is to you, Devender. आपके हॉस्पिटल ने एक सॉफ्टवेयर खरीदा, उस सॉफ्टवेयर को आपने यूज किया, उससे कोई पेशेंट का डेटा लीक हो गया या कोई प्रॉब्लम अराइज हो गई. So are you responsible or your hospital who's responsible, and who has the financial burden, you or the hospital administration?
So, primary responsibility usually rests with the organization that collected, stored, or managed the patient data. We can see this question in a three parts. Like first is the hospital or nursing home. So they are the primary responsible parties. If we see about AI vendor, if the breach occurred on their source, I mean due to poor security design or inadequate data encryption, they are also responsible. But when we as an anesthesiologist may face scrutiny, like if we use unauthorized software, ignored institutional policies, or we set the data improperly, right? So these are the situation where we may face scrutiny according to law.
Right. So according to the HIPAA law, which is there, it holds the hospital administration liable because it says that the problem lies with the person who has the legal role rather than the person who has clicked the deploy. So it is the Hospital Insurance Portability and Accountability Act. So with this, we come to the conclusion. The take-home message is...
Ma'am, I would like to say, I mean,
yeah,
clinical
please.
accountability stays with doctor, and cyber security accountability is usually shared between the institution or technology provider.
Yeah,
So
ma'am. Sometimes the idea is like both MNC and the hospital has to bear the outcome, right? Like because if there is this is a tech related issue, right? Like the whoever has, and here I'm having this assumption that the software is authorized, so it follows every compliances and everything. So in that case, it is probably also the MNC or the AI vendor who has created that software. So accountability on the hospital and the AI vendors both has to bear equally in those cases.
So with this, we come to an end of this panel discussion, and let me summarize some of the important messages which have been conveyed by all the panelists. One, that we have to protect the patient data, and it is totally non-negotiable. Never put protected health information, unique case histories, or sensitive institutional metrics into open public AI models. Maintain the intellectual authorship. The AI should not, should be used as a tool for linguistic polishing or administrative organization, but not for creating the raw data. Never accept the AI output blindly. Verify whatever the output your AI has given you. Document how much AI has been used and report all the incidents, because it is the AI that does not take the responsibility. You take the responsibility. So thank you so much, my dear panelists, for this insight and telling us about all these, giving us new information and insight to this. So do we have any
Perfectly
questions from the
summarized,
audience?
Parul ma'am. Perfectly summarized.
Thank
Perfectly.
you. So let us go to the
Wow.
chat box and see if we have some questions. And yes, we have a lot of questions. This is from Dr. Raghunandan. He says that human intelligence is important. We can only take an opinion from AI. And I think we all agree. And after this discussion, clinical acumen should dictate our actions, but it is conducive to expose our PGs as early to AI as a counterproductive. I think you agree to what he is saying. Bhavna, this is actually, it's your topic. Dr. Raghunandan also says that telemedicine, when it came to India, was non-affordable, and still medical legal implications are there. So would you like to say something about this?
Yes, ma'am, definitely. Telemedicine has come a long way. If we talk about tele-PAC or tele-ICU, definitely it serves a lot of purpose. We can deal with many patients who have to come from so far off, and if they are actually coming and reaching to our destination again and again, it adds to the burden of financial cost as well. So definitely it's a boon. But then second, medical legal aspect, as sir rightly said, can arise because again, it is a sharing of the data. If suppose the airway images are shared via tele-PAC, it can be if the data is leaked outside. So as the DP is very strict about the data privacy, we need to be very vigilant of the data sharing purposes, where all the data is being stored and how it is being retrieved. Again, there needs to be stringent things behind the same. But again, telemedicine is definitely a boon for us.
In fact, for AIMS also, you've developed some program.
Yes, ma'am. We have actually consultation via tele. So many departments like psychiatry or the trauma patients, they are dealt with the help of tele.
Right. So, Bhavna, another question for you. Does AI generated data, can it be detected by using some tools?
Yes, ma'am, definitely. We have tools like Grammarly AI, Turnitin. We have OpenGPT, GPT-0, and many other AI detection tools are available. But then the problem arises when people are using hybrid text. So they may be using their human text and then they are actually polishing it with the help of AI. That becomes a hybrid text, and that becomes very challenging for the software also to detect it. But there are many studies which have proved that if you use 2 or 3 tools together, that increases your chances of getting the AI text generated by the authors.
Right. So with this, we come to an end of our panel discussion. May I request Dr. Kaul sir to say something?
Dr. Parul, you have conducted. Am I audible? Am I audible?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Dr. Parul has conducted this panel discussion in an excellent way. All questions and the answers given by all the panelists, Dr. Bhavna, Dr. Devinder, Dr. Kamna, Mahesh, it has been superb and very enlightening to the audience. It looks that it is Dr. Bhavna's place of work. That is, I think she is from AIMS Rishikesh. Am I right?
Yes, sir. Yes, sir.
They are using this AI
Yes,
in
sir.
anesthesia. I do not know how many of the institutes in the country are using AI in anesthesiology as of now. again, I feel that when we talk of AI in medicine and particularly in anesthesia, it has many sub branches of subspecialties like AI in patient care, AI in OT, AI in the recovery, AI in academics, AI in thesis planning, AI in publications, and all these. This topic is a different one, as has different meaning and different relevance. I also feel very strongly that having almost 450 medical colleges in the country, we need to train the teachers first rather than taking AI into for the students and guiding them. Another point I would like to make for Dr. Parul is, in her questions, she mentioned about AI and IJA. Dr. Parul, please don't mind it, but I would like that when we are holding a RSA webinar, we talk about in general, either in general about medical publications, or don't feel shy in naming JOACP.
Sir, I mentioned JOCP. Later on, when Bhavna had answered,
Yes.
I said specifically
The
that
question was
JOCP is also following these guidelines.
The question was about IJA, but in
Sir,
the end, you made an amendment and you did mention RSS.
yes.
So, in nutshell, I feel that IA, whether you call is AI, whether you call is augmented intelligence or artificial intelligence, is a matter of debate, and it has to be used as an added tool. It can never replace the clinical acumen of the patient. Thank you, Dr. Parul, and all the panelists. It has been an excellent. I have gained a lot from it.
Thank you so
Thank
much.
you very much. But please make some method to train the teachers about it.
Right,
Thank
sir.
you. Thank you. God bless you.
May I request Naveen sir to say something, sir?
Thank you, Parul, and to all the panelists. It's always pleasure to listen all of you, especially the new team members like Dr. Devendra Prajapati also. So
Yes, thank you.
best wishes to all, and thank you. We look forward to continuous learning. AI will take some time for us to be artificially intelligent. Thank you very much.
Thank you so much, sir. So as we come to the end of this webinar by RSA Uttarakhand, we are humbled by the opportunity given to us by Research Society of Anesthesia National. We are extremely grateful to Dr. Naveen sir for encouraging us with this Zara Hatke topic. And we would like to express our gratitude to Tej Kaul sir for always guiding us and encouraging us, and Dr. Vishal Singla for his help. I'm grateful to all the GC members who were there and who have supported us. Thank you to the technical team for their smooth functioning. I'm extremely lucky that I have such beautiful panelists who are younger in age, but they're older in experience with the use of AI. And at the end, please, I'm really grateful to all the audience who have stayed up with us after their hectic schedule and they have listened to this webinar. I hope you take something good from this. And thank you so much, everyone. Sir, with your permission, can we conclude now?
Thank you very much. Long live Research Society of Anesthesiology.
Long
Thank you
live
very
Research
much.
Society. Thank you.
Long live.
Long live us.
Long live ours.
Long live RSA.
Long
Long live our recipe.